Well, I am Vikram Dogra from the University of Rochester, New York. I am the Associate Chair for Research and Education and also Director of Ultrasound. Today I will be presenting first trimester bleeding, which is very important in day-to-day practice. I am going to present first trimester bleeding in coming about 30 minutes or so. Before we can proceed to understand what is first trimester bleeding, it is very important to know about the normal gestation, and a gestational sac should be identified with transvaginal examination approximately with 2000 international units of beta hCG and with transabdominal sonogram at about 6500 international units of beta hCG. A subnormal increase in the serum beta hCG in early pregnancy less than 66% in 48 hours suggests the pregnancy is not viable, and progesterone concentration greater than 25 nanogram is suggestive of an intrauterine pregnancy in most cases, and a level below 5 nanogram indicates a non-viable pregnancy. Gestational sac is usually visible at about 5 weeks. When you see sac and a yolk sac, that means that the pregnancy is about 5.5 weeks, and when you see embryo with the above 2, it is 6 weeks, and at 5 millimeter of CRL length, that is crown rump length, the cardiac activity should be present, and one should measure the CRL length at 7 millimeter. I must clarify that gestational sac is not an embryological term. It is a ultrasound term which simply means an extracoelomic cavity. When you see it by sonogram, we call it gestational sac. This is a great example showing the double decidual sac sign, where you can see that there is an embryo within the calipers, which is surrounded by a nice amniotic cavity, and there is this double chorionic activity, which is the decidua capsularis, and you have decidua paritalis at this level, and effacement of the endometrial cavity, and you have a corresponding diagrammatic representation of the same. Sometimes the decidual reaction can be very severe, and one should not mistake this for the herediform mole. It is very important to follow these cases with a few weeks of interval, and this is one such example where you find that there was a marked decidual reaction. However, it subsequently proved to be intrauterine pregnancy, and patient delivered a normal healthy baby. Yolk sac is a definite sign of intrauterine pregnancy, and it is very important that one should call that intrauterine pregnancy is present only when the yolk sac is seen, and not at the presence of simply gestational sac. Now, spontaneous abortion is the biggest category which accounts for the majority of cases of patients who present with bleeding in first trimester, and it is defined as a pregnancy which terminates before the completion of about 20th week of gestation, and as you can see that 70% of spontaneous abortions are due to genetic abnormalities. Of course, trisomy is the major culprit in this, and about 65% of spontaneous abortions occur before the 16 weeks of gestation. Now, if you are into classification of spontaneous abortion, you can classify them into threatened abortion, incomplete abortion, missed abortion, complete abortion, and inevitable abortion. I am not going to go into the details as they are self-evident on the slide, and I would encourage the audience to read through it. But I certainly want to draw an attention that you can see a pseudogestational sac in a ectopic pregnancy, and the way to differentiate that from a true gestational sac is that the intrauterine pregnancy has an eccentric location within the endometrial cavity, as you can see in this, and you can see that the endometrial cavity is right here, which is effaced, and in this you can see that this is right in the center of the endometrial cavity with a lot of decidual cast, and this is of course a no brainer to differentiate between the true and the pseudogestational sac, which you may see in ectopic pregnancy. This is just to highlight that the true gestational sac has a hyperechoic wall, and that is because of the surrounding chorionic villi and decidual reaction. Now, the transvaginal ultrasound features of pregnancy failure are very important to understand, and as you can see given in this slide, when you have an absence of intrauterine gestational sac with serum beta hCG level above the discriminatory level of 1000, you need to exclude the presence of an ectopic pregnancy. Similarly, I am sure the audience can go through this slide and see that the embryo of 5 millimeter and above, if you have no cardiac activity, you know that this corresponds to embryonic demise. This is a great example of an anembryonic pregnancy, where you can see that the gestational sac is very large, it is slightly irregular, and there is no evidence of embryonic pole or a yolk sac. This is an example of an abnormal gestational sac. You can see that the sac is irregular in appearance, it is irregular in appearance, and there is no embryo or yolk sac. So, this is an abnormal gestational sac, suggesting that the patient has a non-viable intrauterine pregnancy. Now, this is a very good example. Sometimes you may see abortion in progress. This is one such example. You can see endometrial cavity within these arrowheads, where you can see that there is some decidual cast and some hemorrhage within the endometrial cavity, but the gestational sac has been dislodged and is on the way out. However, these two examples are not the abortion in progress. This is an example of the cervical pregnancy. Here you can see a nice endometrial cavity. This is the cervical canal, and you can see that the ectopic pregnancy is implanted at the level of the cervix, and the way to differentiate these two is what is called a sliding sign. If you put the endovaginal probe and you try to push this, you will be able to slide this gestational sac, but you will not be able to slide these two. And if you put color flow Doppler, you would see a lot of activity, and of course, on real time you will see cardiac activity that confirms that this to be cervical pregnancy. This is another example of abortion in progress. You can see this gestational sac is low lying and is on the way to be expelled from the cervix, and in this case you can see in transabdominal sonogram, this is a cervical pregnancy, this is the vagina, and here you can see on transvaginal sonogram there is a big large live embryo at the level of the cervix. This is a good example of subchorionic hemorrhage. You can see that this gestational sac is irregular. You have a decidual cast secondary to and chorionic villi, and this is a small subchorionic hemorrhage. These cases need to be followed at a regular interval to prove the viability of the fetus. However, the size of the subchorionic hemorrhage does not correlate with the survival or non-survival of the IUP. This is an example of a missed abortion when the concept of the products of conception are retained and are being reabsorbed, and you can see this embryo is very small corresponding to this large gestational sac. Therefore, one knows that this is a missed abortion. The other major category that presents with retained with first trimester bleeding is retained products of conception, and it is very important to differentiate this from other entities. Now, they typically consist of the retained placental tissue, and on a gray scale you would see an echogenic mass in the uterine cavity. However, color flow Doppler may help to visualize vascularity, but absence of vascularity should not dissuade you from making that diagnosis. This is a great example of retained products of conception. You can see that the endometrial cavity has a marked hyperechoic appearance. On transvaginal sonogram, you can see that there are some anechoic areas. This is the hyperechoic mass with increased vascularity, and that is consistent with retained products of conception. The third major category responsible for the first trimester bleeding is what is called the ectopic pregnancy, and this is very important entity for one to understand the cause of the first trimester bleeding. 95% of first ectopic pregnancies occur within the ampullary or the isthmic portion of the fallopian tube. Adnexal mass that contain the yolk sac or viable embryo is certainly a definite proof of an ectopic pregnancy. However, the commonest thing what one finds is an extra ovarian adnexal mass is the most common sonographic finding. Most of the people ask me, what about the ovarian pregnancy? Please note that the ovarian pregnancy is extremely rare, and if you find, certainly it will be worth publishing a case report. Tubal ring sign is the second most common sonographic finding and is seen as a hyperechoic ring around the gestational sac, and will also demonstrate increased vascularity on club flow Doppler, which can be called the ring of fire, and that can also be seen in corpus luteal cyst and in many other entities. Please note that about 1/3 of the ectopic pregnancies will have a normal pelvic sonogram on transvaginal sonography, and you may not say any abnormality. The uterine findings in ectopic pregnancy include the uterus may be normal, thick decidual cast, and gestational sac. And extrauterine findings, I just mentioned some in my previous slide, and I would encourage my audience to go through this list and also to read through this article as referenced at the bottom. This is a great example of a tubal ring sign. You can see this is an ovary because it is a big black hole consistent with a follicle, and you have a large thickened fallopian tube secondary to chorionic villi and decidual reaction with a gestational sac, and on the pulse Doppler you can see there is a high flow low resistance, and a club flow Doppler reveals a ring of fire, and that certainly confirms a lot of increased vascularity, and that is consistent with a ectopic pregnancy. Nowadays, a lot of people undergo C-section that results in a scar in the lower uterine segment, and sometimes you can have a pregnancy at that level, and that is called the scar pregnancy. And here on the gray scale you can see this is the cervix, this is the anterior wall of the lower part of the uterus showing a scar. There is a nice implantation within the myometrium. This is the embryo, and this is the amniotic cavity, and this is the increased vascularity in the decidua as well as chorionic villi, resulting in placental implantation. The next category, which is very important to understand for the first trimester bleeding, is the gestational trophoblastic disease, and herpetiform mole forms the maximum bulk of this entity. That can be complete mole or a partial mole, and you can have gestational trophoblastic tumors comprising of the following tumors, including placental site trophoblastic tumor. You all are aware of the presentation of molar pregnancy, and I can only say that please note that this patient is present with hypertension before 24 weeks, hyperemesis gravidarum, thyrotoxicosis, and a passage of grape-like vesicles transvaginally. You can have an herpetiform mole that constitutes about 80% of the cases of the GTT, and there is no accompanying embryo or fetus with this, and uterine frontal height is usually more than expected for the gestational age, and serum beta hCG levels are markedly elevated in the range of thousands, such as 30 to 40,000 range. Now, molar changes can be detected from 8 weeks of pregnancy. Snowstorm appearance can be seen with the low frequency transabdominal scanning. when you use high frequency transvaginal transducers, you would see numerous discrete anechoic cystic spaces secondary to hydropic villi and partial mole. If you have one, you will always see an intrauterine embryo along with the molar changes. Now, thick lutein ovarian cyst, I am sure you all are aware, occur in about 25 to 60% of cases. Ovaries are enlarged with multiple cysts having a soap bubble or spoke wheel appearance. This is a great example of a herpetiform mole that is complete. On sonogram, you can see that there are multiple cystic areas within the endometrial cavity with hyperechoic areas interspersed in between, and on MR with gadolinium enhancement, you can see that the uterine musculature is enhancing and the cystic areas show no evidence of enhancement, and certainly this is well published in Plathi et al. Radiology clinics of 2004, and I would encourage you to read this. This is an example of partial mole where you can see placental implantation with yolk sac and embryo. So, this is a mole developing within the placental implantation site, accompanied by a partial with embryo and with yolk sac. This is consistent with a partial mole. Now, sometimes this you can have an invasive mole, and as you can see that this entity invades the myometrium and shows marked hypervascularity, as you can see in this image, and on MRT2 weighted images it looks hyper intense. This is the normal appearance of the endometrial cavity, and this is the cervix, and bladder is bright on T2 weighted sequence. The next category which I want to discuss with you regarding the first trimester bleeding is arteriovenous malformation of the uterus. It is not much discussed in most of literature. These malformations are rare, but can be life threatening. They can be congenital or acquired. Congenital AVMs have multiple arteriovenous communications, and acquired lesions are arteriovenous fistulas between a single artery and a vein, and vascular malformations persist following the treatment in 10 to 15% of patients with gestational trophoblastic disease. Now, on a gray scale, you would see multiple anechoic spaces with mosaic pattern of color signal within the cystic space on a color Doppler ultrasound, but this usually is within the myometrium and not in the endometrial cavity. And here is a great example. This young lady presents with spontaneous abortion. She had a history of actually multiple spontaneous abortions, and this time she presented with bleeding after spontaneous abortion. On a gray scale, you see a hyperechoic area. On a color flow Doppler, you see eccentric mosaic pattern color flow away from the endometrial cavity, and when you put spectral Doppler, you see arterialized blood flow pattern, and this is sine qua non of the AVM. Of course, this patient did undergo MR evaluation, and that was confirmed to be AVM, and that was treated with a coil embolization by the interventional radiologist, and subsequently patient went on to conceive and deliver normal baby. This is just an outline of the first trimester ultrasound, proposed algorithm how to evaluate women in this, and this is from McGagan et al. Diagnostic ultrasound. How do they approach, and this is their algorithm. I would encourage the readers to follow this. At this point, I would conclude and say I enjoyed giving this presentation.